Great. So I think we're ready to start. So I'd just like to say hello to everybody. Thank you for joining us for another of our digital Infoday sessions. My name's Monica. I'm a Clinical Practice Services Senior Projects Officer at Myeloma UK, which is a very long title, I know. This means I predominantly work on our CSET programme, which is Clinical Service Excellence Programme. This is a hospital accreditation programme, and it presents quality standards awards for excellent patient care in hospitals all around the UK. So that's me. So welcome. Before we begin this evening, I just want to go over a few housekeeping bits and pieces with you. Just want to let everybody know that this session is being recorded, and it's going to be available to watch on our Facebook page and on the website soon after. We'll be popping the website links, details of the publications and useful information into the chat box throughout the event and the presentation. So if you have any questions that you'd like to ask our expert, please use the Q&A box at the bottom or top of your Zoom screen, and we'll try to answer as many of these as we can. We've already had a lot of questions come in. It's a popular topic, this one is, but you know, do put in your questions and we'll get through as many as we can throughout. So just a little bit about Myeloma UK. Some of you may not be that familiar with our organisation, so just to tell you briefly about who we are and what we do. Myeloma UK exists to support all of those affected by myeloma and related conditions. These include smouldering myeloma, MGUS, and AL amyloidosis. We're patient-focused and we aim to empower, inform, and support patients in everything we do. As an organisation, we do rely on the generosity and kindness of our supporters who fundraise and donate for us. And Myeloma UK receives no core government funding, so your support is vital, and we're truly thankful for all your contributions as they allow us to continue working to help patients, their families and friends, and put on events just like this one this evening. So moving on, tonight's digital event is on gastrointestinal disturbances. So something that there's a lot of interest in, this something that affects all of us in normal life, but in myeloma can, cause some problems. So in this session, you will hear our expert talk about the symptoms, the causes, and the treatment for different gastrointestinal disturbances that can affect you in myeloma. And our speaker is going to discuss how to treat potential complications, and we'll give you some top tips on prevention and self-management. So with all that in mind, let's get started. So I'm delighted to welcome this evening's expert, Craig Simon. Craig is a nurse consultant in the Haematology, Oncology and Acute Care Division at the Clatterbridge Cancer Centre, NHS Foundation Trust in Liverpool. So welcome, Craig. It's really nice to have you here to present for us. Really looking forward to your slides, what you've got to talk to us about on GI, as we call them, disturbances. So I'll hand over to you to begin. Thank you.
Thank you very much, Monica. Good evening, everyone, and thank you for joining. Thanks also to Myeloma UK for inviting me to talk to you all tonight. And as Monica says, I'm going to be discussing gastrointestinal disturbances. So what will this talk cover? So I'm going to discuss what gastrointestinal or GI disturbances are, what can cause these disturbances in myeloma, and then how we can treat and manage such disturbances. So what are GI disturbances? So they're issues involving the stomach and the intestines, and these can include nausea or feeling sick, actually vomiting, constipation and diarrhea, and I will discuss each in turn on the following slides over the next 30 minutes or so, and then there'll be time to answer questions that may come in via the Q&A or the pre-submitted ones. So these disturbances can last a short time, so just a few days, and we call these acute, or they can last a longer time, e.g. more than 2 weeks, and we label this as chronic. So I'm going to start by discussing nausea and vomiting. So what symptoms would you expect with nausea and vomiting? So feeling like you need to vomit or actually vomiting. It can make you feel queasy. It can be dizziness. You can have excessive sweating and clamminess. And some of these symptoms can be preceded by a dry mouth. So there are some complications of nausea and vomiting. So if these symptoms go on for any prolonged length of time, they can cause dehydration. They can cause unpleasant stomach pains. And if you have vomiting for a period of time, then it can cause damage to your throat. What are the potential causes of nausea and vomiting? So this list is not exhaustive. There's quite a few. So the myeloma treatment.
Could I just step in briefly? Do you mind speaking up a little bit? Where I think we've had a comment that they are someone's struggling to hear. So
yeah, no problem.
We'll try that and see if it works. But do let us know if you can't hear, and we will try and sort that out. So bear with us.
Yep. So the causes of nausea and vomiting. So this list is not exhaustive. There's quite a few causes, but the myeloma treatment itself and some of the supportive treatments that we use in myeloma can cause nausea and vomiting directly. So there's some drugs listed here, and I've added a couple of my own, which are probably a more common side effect is nausea and vomiting. So they include ixazomib and panobinostat. Infection can cause nausea and vomiting, so viral gastroenteritis. Food poisoning, so some foods that you may have eaten, and anybody going on to chemotherapy will be given dietary advice prior to starting chemotherapy to try and minimize the risk of food poisoning. Stress, anxiety, and nervousness can cause nausea and vomiting. And there is a type of nausea and vomiting known as anticipatory nausea and vomiting, where just the thought of coming into hospital for appointments or certain smells that you may associate with being in the hospital can cause you to feel or actually be sick. Pain in itself can also make you feel queasy or make you have nausea and vomiting. And also some of the analgesia that we use for pain can have the side effect of causing nausea and vomiting. So particularly opioid-based painkillers like morphine or codeine-based painkillers can cause nausea and vomiting. And then also a complication of myeloma itself, a high calcium level, hypercalcemia, can make people feel sick and actually make you vomit. So how do we treat it if you have this side effect? So it really depends on the cause. And what I would say, and a running theme throughout the next 30 minutes, will be that you should always seek advice from your treating team first to get the best treatment recommendation or management advice. But mainstay of nausea and vomiting treatment is to give you medication to try and stop it in the first place, and these drugs are known as antiemetics or anti-sickness drugs, and there's a whole heap of them. There's lots. Some are listed here, so metoclopramide or Maxilon, Granesitron, which I can't pronounce, or ondansetron, but there's lots more, so cyclizine, levomiprazole, I could go on and on. However, what I would say is some anti-sickness medication can interact with other medication that you may be taking, which is why I would suggest always seeking advice first. And some anti-sickness tablets can also cause things like ECG changes, depending on what chemotherapy you may be having for your myeloma. So one listed there on Dansitron is known to cause something called QT elongation. And this can also be a complication of some of the chemotherapies we give to actually treat myeloma. So like I say, always check first. I've also put here that you shouldn't wait until you feel sick to take the anti-sickness tablets. And I'm making the analogy with some of the people that I look after, that it's much more difficult trying to put a fire out once it's started than if you prevent the fire from starting in the first place. So don't wait until you're actually being sick to take your anti-sickness tablets. I'd take them if they're prescribed for you to try and preempt the fact that you may be feeling sick. And if your antiemetics aren't working, then ask to try a different one. As I've said, there's lots that we can choose from now. And there are some specific for certain types of nausea and vomiting, depending on what we think the cause may be. So again, as an example, just going back to the anticipatory nausea that I talked about, there's now a specific anti-sickness that we can give to help with that specific type of nausea and vomiting. We may be able to treat the nausea and vomiting with painkillers if we think that it's pain that is causing you to feel like this. But always please remember, don't take non-steroidal anti-inflammatory drugs if you are somebody that has been diagnosed as myeloma. This particular type of painkiller can really upset your kidneys, which is why we don't recommend this type of painkiller. And then we can also give antibiotics, but there's a caveat to this one. I would only give antibiotics for nausea and vomiting if we have proven that there is definitely an infective cause for the nausea and vomiting. And I'll come on to why in a few slides' time, but taking antibiotics shouldn't be done lightly and should only be done if we've got proof that there is an infection there causing the symptoms. Sorry, I make the point also with anti-sickness tablets that if you're taking multiple anti-sickness tablets, they can actually cancel out their own effects. And this is something that I've only recently learned myself. So cyclizine and metoclopramide, if you take them together, they actually cancel out each other's beneficial effect, which again is why you should seek advice before starting any new medications. So as well as medical management, there are also some things that you could do yourself to try and manage the symptoms of nausea and vomiting. So keep drinking. So small sips tends to be the advice that we would give. Overdoing it with fluids all in one go can actually have a counter effect of making you feel bloated and making you feel nauseous. So small sips throughout the day. And we would recommend that this is fairly plain drinks, so still in sparkling water, or fizzy drinks that aren't caffeinated. Caffeinated drinks can have the side effect of dehydrating you rather than hydrating you. So if you're going to have fizzy drinks, try and stay away from the caffeine, caffeine-free and also sugar-free as well. Eat plain food little and often. Although I wouldn't worry too much in the acute phase of getting diet down, as long as you're trying to keep the fluids up. So fluids is initially more important than diet in the acute phase, and that's to protect your kidney function, which obviously in myeloma for some people can be fragile anyway. So in the first few days that you may be suffering from nausea and vomiting, don't worry too much about diet, but try and keep up with the fluids. If you are going to try and attempt some food, plain food, little and often. Don't try and overface yourself with big meals. Again, that might have a counter effect of making you feel bloated. Adjusting your eating times relative to your anti-myeloma treatment. I think there's this thing where we have to try and eat 3 square meals a day at certain times in the day, but that all goes out of the window when you're on treatment for things like myeloma. It doesn't matter if you don't stick to the 3 square meals a day, as long as you're snacking throughout the day and getting something in. This next one's a really important one, and it'll become a recurrent theme throughout some more slides that we'll go on to in a bit, but avoid spicy and particularly fatty foods and acidic foods. They can cause problems if you've got GI disturbance. And then try eating foods that are cold or room temperature rather than hot foods. These tend to be better tolerated if you're feeling sick. And if you can't eat, then try high-calorie drinks. But again, please speak to your treating centre before you start any of these. Some high-calorie drinks can also have added electrolytes in with them. So it's best to seek advice first before trying anything over the counter. So some more self-management tips. So ginger is a very good natural antiemetic. So you can get ginger tea, non-alcoholic ginger beer and ginger biscuits. Mint as well has antiemetic properties. So again, mint tea. Try sucking on mints, as in the sweets, or chewing on some gum, which will also help if you're suffering with a dry mouth, as this should stimulate saliva production. Avoid strong smells, so strong perfumes, strong aftershaves, as these might actually make you feel sick in themselves. If you do find that there is a particular smell, like lavender or a gentle smell that you enjoy, then a perfumed handkerchief can mask hospital smells if there is an element of anticipatory nausea. So if the smell of an alka wipe that they may use to dress lines or clean lines, if that can precede you feeling a bit sick, then a perfumed handkerchief when you go into the hospital can mask this. And then there's relaxation aids and complementary therapies. And I've jotted down here that some people find acupuncture can be beneficial for nausea and vomiting. But again, sound like a broken record, but please seek advice from your treating team prior to starting any over-the-counter or alternative therapy. And then I've also made a note here that sometimes as your treating team, we may need help from clinical psychologists if there's a psychosomatic component, such as anticipatory nausea and vomiting, as there are non-medical interventions, such as CBT, so cognitive behavioral therapy, that might just help break that association that may be causing some of the nausea and vomiting symptoms that you may be experiencing. Okay, so moving on to constipation. So these slides will follow a similar pattern, so symptoms and then causes and treatment. So symptoms of constipation. So this is difficult to kind of have a one box fits all. So knowing what is normal for you before you start on any treatments for myeloma is really important. So if you're able to tell your treating team, either at diagnosis or just prior to you starting on treatment, what is your kind of normal bowel habit, then that gives us good background information when we're assessing you cycle by cycle in the clinic as to what is then abnormal for you and what we may need to do something about. But we've just jotted down here that this could be classified as fewer than 3 bowel movements a week. You could get pain or discomfort when you're opening your bowels, and it can be passing small hard stools. Feeling tired and bloated can be a symptom of constipation, and also a feeling that you've not completely emptied your bowels. So you may be able to go to the toilet, you may be able to pass some poo, but you feel straight after that you've not completely emptied your bowels and you're still uncomfortable. So what can the complications be of constipation? So you can get a swollen or painful stomach, so it can be visibly bloated. You can get stomach cramps, which can be really quite debilitating and can really affect your quality of life. You can lose your appetite. If you're constipated, you've not been able to pass any stool, and that's going to take up space in your tummy, and you just don't feel like eating because you're constantly feeling full. Constipation itself can cause nausea and or vomiting. And what I would say is a red flag symptom to us in the hospital is if you're vomiting and it's what we call coffee ground vomit, or it's foul smelling. Then if you're constipated and you're vomiting coffee ground vomit, so vomit that's got little bits of brown in it, or it's foul smelling, then we need to know about that straight away and you need to get into hospital. Headache and thirst can be a complication of constipation. And the reason I mentioned about coffee ground vomit or foul smelling vomit is that this can be a sign that you've got a bowel blockage. There's nowhere for it to go down the bottom end, so it's coming out of the top end. A bowel blockage, can also cause very runny diarrhea, something that we call overflow. So if you've got diarrhea, but you're feeling full as well, then your treating team needs to know about that, as that could be actually a late sign of constipation. And left untreated, these can cause serious complications requiring surgery, bowel resection, and permanent life-changing effects such as stoma creation. So it's really, really important that you let your treating team know as soon as you're worried about any of these symptoms. So what can cause constipation? So again, the myeloma treatments and supportive treatments themselves can cause constipation. And I've listed some of the common drugs here. So thalidomide, lenalidomide, and bortezomib are all well known for causing constipation. If you've had nausea and vomiting and we've put you on some stuff to try and correct that, then the anti-sickness drugs themselves can cause constipation. So ondansetron in particular is well known for causing this complication. And then strong painkillers. So again, the opioids, so morphine-based painkillers and codeine can cause constipation. It's always worth, if you're going on to those types of drugs, to ask your treating centre if you can have some laxatives just in hand in case you need them, and then you're not having to try and chase people to try and get those drugs should you have that complication. Again, a high calcium can cause constipation, and this can be as a result of myeloma bone disease. And then if you're not feeling like eating and drinking, if you're not putting much in, then that can cause constipation. And likewise, if you're not keeping yourself nicely hydrated, then dehydration can cause you to get a little bit bunged up. Lack of activity and poor mobility, this can cause constipation. And then stress, anxiety, and depression as well. And the change in your routine. So a lot of the treatments that we give are causing you to come into hospital more frequently than you would have had to. So just that change in routine can upset your normal bowel habit. So if you do suffer from constipation, what treatments can we use? So I've already mentioned some laxatives. And again, please seek advice from your treating team first before trying any treatments or buying anything over the counter. So oral laxatives, again, like the antiemetics, the anti-sickness tablets, there's lots and lots of different types that all work in different ways, depending on how severe we think the constipation may be. If despite these oral laxatives, you're still feeling bunged up, then a suppository or an enema may be offered. And sometimes this needs to be done either as a day case in the hospital setting. And the reason for that is that we may need to investigate you prior to starting such treatment. So we may want to send some samples of stool, and we may want to do some scans just to check for any blockages before we give you any of these treatments. So again, please seek advice from your treating team. So that's the medical management, what we may be able to do to help if you are constipated, but what can you do in terms of self-management? So increasing the amount of fiber in your diet. So again, eating small amounts regularly throughout the day. And I've listed here what a high fiber diet may consist of. So bran-based cereal, fruit and vegetables, beans and pulses, swapping from white bread to whole grain bread, and then prunes and other dried fruits like apricots and things like that. And alongside a high fiber diet, staying hydrated, so drinking plenty of water, has lots and lots of benefits for somebody who's got myeloma. So it keeps you nicely hydrated, keeps those kidneys working well, and also will hopefully help with overall gut health. Conversely to the advice I was given for nausea and vomiting, hot drinks can help, but again, avoid caffeinated based drinks. So if you like tea and coffee, try and switch these over to decaf. Again, that's because caffeine is a known diuretic, so it can actually, even though you think you're drinking plenty, it can actually dehydrate rather than rehydrate. And similarly for alcohol, so alcohol will dehydrate you, and it also won't help if, because of your constipation, you're feeling a bit nauseous. So please avoid alcohol. And then there's just a note here of, if you don't feel like eating things like fruit and vegetables in their whole form, then try blending these into smoothies And likewise, beans and pulses, you can blitz them down into sauces. Some more self-management tips for constipation. So reducing or limiting the amount of refined food that you have. So again, white bread, cakes, sugar, things like that. They don't pass through the gut very well. Take regular gentle exercise if you can. So just trying to keep as mobile as you can. And this may not be going outside if you don't feel up to it. What I advise some of my patients is, if they're not feeling like doing a walk around the block, just getting up from the chair and wandering to the kitchen, grabbing a drink of water and then heading back is regular gentle exercise. And it's also got the benefit that you grab yourself a drink of water and you keep yourself well hydrated. This next one's easier said than done, isn't it? Minimizing stress as much as you can. But if you've just had a new diagnosis, or you've just found out that your myeloma has relapsed and you're needing to go on to new treatment, then that in itself is going to cause you to feel stressed. Using a footstool at the toilet, so avoiding straining. So without getting too graphic, there's a particular position that is best for trying to pass stool, and that is actually trying to get your knees higher than your hips. So if when you sat on the toilet, you've got a footstool or someone that can raise your legs, then that can just help you pass motion. And the reason we say avoid straining is that can cause things like hemorrhoids, piles, and can cause you to bleed, which then just adds to whatever stress you may already be going through. And then natural treatments, so you can get fiber supplements, you can get flaxseed or linseed, and then syrup of figs, and these are all available over the counter and from health food shops. But again, please seek advice from your treating team, just in case there's any interactions between these and any other drugs that you may be taking. The next slide, I think, is just a quote from one of the Myeloma UK resources. So some of the chemotherapy pills make you constipated, so trying to adjust your diet to make sure you're getting enough fruit, veg, and nuts. And this person bought a juicer, which they use daily in the first year. You can get quite experimental with juices as well. You can throw stuff in and see how it tastes. Okay, so moving on to the converse of constipation, diarrhea. So again, knowing what is normal for you helps us as your treating team know what is abnormal. But we've categorized diarrhea symptoms here as more than 3 loose or watery bowel movements per day. You can get cramping stomach pains and an urgent need to go to the toilet, and sometimes you're not able to actually make it to the toilet. And all of these symptoms can come hand in hand. So diarrhea can make you feel nauseous or actually make you vomit. You can get fever, and obviously if you have diarrhea and fever, then we really need to know about that, because that could be an infective cause. And if you're on treatment, it's a serious problem, and we need to get you in and have a look at you. Diarrhea can cause a headache, so this can be a knock-on from being dehydrated. And if you have diarrhea, then you're not going to feel like eating much, so it can cause a loss of appetite, which in the chronic phase can cause weight loss. And then there is the serious complication of dehydration, which in turn can lead to something called acute kidney injury, or AKI. And in somebody with fragile kidney function, this can become permanent and or progressive, leading to serious complications such as renal failure and then the need for dialysis. What can cause diarrhea? So again, the myeloma treatments themselves and supportive treatments can cause diarrhea. So immediate onset. So again, drugs like bortezomib or Velcade can cause both constipation and diarrhea. And then panobinostat, again, is well known for its GI complications. Late onset, so lenalidomide in particular can cause diarrhea. And I'll talk specifically about a lenalidomide specific complication in a minute. And then pomalidomide as well can also cause late onset diarrhea. Infection. So going back to my earlier slide about antibiotics, inappropriate use of antibiotics or overuse of antibiotics can cause a particular type of infective diarrhea called CDT, or Clostridium difficile toxin. So that's why we're always very cautious about the use of antibiotics and making sure that we're using them appropriately. Constipation, as we've said, can cause overflow diarrhea in the later stages, and also laxatives. So if you find that you've been constipated, we've prescribed you some laxatives, but you're particularly sensitive to them, or we've gone a bit overboard on the dosage, then you may go the other way and you may end up with diarrhea. Sometimes, as medics, we can be prescribing you stuff that you may not particularly need because you had it the last cycle. So always just keep us updated when you're having consultations with us as to what you may or may not need and what your current symptoms are. Don't please just keep taking stuff that we've given you because we've given it to you. If we prescribed you laxatives one cycle because you were constipated, but now your bowel habit's okay, but you continue taking the laxatives, then you're going to end up with diarrhea. And then again, stress, anxiety, and depression can cause GI upset and diarrhea. And now there's a specific complication of lenalidomide treatment in particular, which is known as bile acid malabsorption, or BAM for short. It's important to note that not everyone who takes lenalidomide will suffer with this complication, but I'm going to spend the next few minutes just talking about this in particular. So what is bile acid malabsorption, or BAM? So we all produce bile acids. These help us break down and absorb fats and help remove waste products. But in most people, these bile acids get reabsorbed as stuff passes through the gut. However, in some people who take lenalidomide in particular, the lenalidomide upsets that process of reabsorbing the bile acids. So what happens is we don't reabsorb them and the bile acids get into the small bowel, irritate the small bowel and cause diarrhea. So patients with bile acid malabsorption don't absorb these bile acids back into the gut properly. How do we diagnose this? So it's a specific test. So we need to think that this might be what is going on and then order this specific test, which is known as a CCAT scan. And this is done through nuclear medicine departments in hospitals. So a CCAT scan is 2 visits a week apart where they're specifically testing whether you're reabsorbing your bile acids properly. For anybody who's interested, CCAT stands for the name of the radioactive tracer that they use. And I'm going to probably trip myself up with the name of this now, but it's 75 selenium homocholic acid taurine. So if ever that comes up in a quiz question, you now know the answer to what CCAT stands for. What I would say is please follow the instructions given to you prior to any scan that may have been arranged for you, as sometimes medications might need to be stopped before the scan because certain medications can affect the reliability of the results. And just for anybody who may be worried about undergoing a CCAT scan, whether it being a nuclear medicine or a radioactive test, the radioactivity exposure through this test is the same that you would be subjected to naturally over the course of 2 months without you having the scan. So it's a really small dose, but it's a really useful test, which can give us a yes or no answer as to whether you have this particular complication. And then if we do prove that you have bile acid malabsorption, we can treat it with supportive therapies and dietary changes, again, as recommended by your healthcare team. So just moving on to treatments for diarrhea. So again, this depends on the cause. Sometimes the diarrhea may resolve on its own, and in itself, a day or two of diarrhea or a one-off episode isn't unduly worrying. It's much more worrying if it goes on for a long period of time. And there's some prescribed treatments that we can use here that are listed. So anti-motility drugs, so things like loperamide, which you can also buy over the counter. All of these drugs that we could potentially use also have side effects themselves. So loperamide can cause abdominal cramps, it can cause dizziness and excess wind. We can try and constipate you if you have diarrhea by using opioid painkillers. So we can give codeine or morphine-based painkillers. Again, we've talked about some of the potential complications of these drugs. So they can make you feel sick, they can make you feel sleepy, and they can also cause some abdominal pain. And then we can also, if you're struggling with stomach cramps, we can give antispasmodic drugs or drugs that relax the muscles in the tummy. So things like Buscopan, again, which can be bought over the counter, atropine. I won't try and pronounce that other one. You can read it there. And again, these can have the side effect of bloating you, also causing some heartburn, constipation and dry mouth. Given that you can buy some of these drugs over the counter, please seek advice first before you do that, just so we can make sure that it's the right treatment for you, depending on what we think the cause is. So I've mentioned that some of these can be bought over the counter and that you need to check with your healthcare team before taking any new treatments. Again, painkillers can help relieve discomfort, but that knows again to please avoid non-steroidal anti-inflammatories like ibuprofen, naproxen, things like that. Please don't take them. And then there are, as I mentioned previously, there are some specific treatments if we prove that your diarrhea is caused by bile acid malabsorption. So we can give a certain type of drug called a sequestrant, which help absorb those bile salts, given that the lenalidomide is stopping you from doing that yourself. And the name of these drugs include Questrin or Colisevalam. If we prove that it is bile acid malabsorption in particular, then reducing your fat intake will particularly help with this complication. Just a note for anybody who may have proven bile acid malabsorption, we don't usually have to stop your chemotherapy, so don't be worried that if you think that your diarrhea is caused by bile acid malabsorption, that by reporting it, we're going to have to stop your lenalidomide. I know it's a long-term treatment and a very effective treatment for myeloma, and if we do prove that you've got bile acid malabsorption, that doesn't mean that we would have to then stop that treatment. We can manage the bile acid malabsorption and continue the lenalidomide. It's also not thought to be dose-related, so we tend not to see any benefit in reducing somebody's dose. The key is to prove that you have it and then give you the sequestrants to help with it. And most people who have bile acid malabsorption can manage their diarrhea with the sequestrants and perfectly happily carry on with their lenalidomide treatment. So again, that's what we can do to help you once you report these symptoms. So what can you do to help yourself if you're suffering from diarrhea? So again, please keep well hydrated. It's really, really important in diarrhea. It doesn't take long, especially if you have profuse diarrhea, to lose a lot of fluid. So keeping hydrated and sometimes using rehydration salts can be really important. Eating frequent small meals and eating slowly. And these meals should be plain light foods, so things like soup, chicken soup, clear broths, plain rice, potatoes, bananas, bread and pasta can all help with diarrhea. Again, avoiding alcohol and caffeinated drinks and avoiding spiced or fatty foods. And if the diarrhea is caused by antibiotics, then sometimes live yogurt can help. But please, again, seek advice before starting any live culture yogurts. And that's just the note there. So avoid if you have a low white blood cell count. And if we get round to that later on, there is a specific question that came through on the Q&A about that, pre and probiotics. So maybe we can address that then. Again, we may need to send stool samples to rule out infection. So don't start any self-management treatment until you've reported your symptoms to the hospital, as it's highly likely that they're going to want to send off some samples just to rule out an infective cause. And if you take over-the-counter loperamide in particular, without advice, then it can actually make the situation worse, especially if you have an infection or if you've got undiagnosed bile acid malabsorption. You're going to hold on to the stuff that your body's trying to get rid of in terms of the infection or the bile acids, and it can just amplify the situation. So please seek advice first, as we may also need to do scans like we've discussed, such as a CCAT. Some more self-management tips. So planning ahead for outings. So knowing where your nearest toilet is. Obviously, symptom of diarrhea in particular, out of all of the GI complications I've discussed tonight, diarrhea can be one of the most problematic and the most embarrassing. So yeah, planning ahead for outings means that hopefully you're able to be pre-prepared and you'll know where your nearest toilet is. So you minimizing that knock-on effect of any potential impact to your quality of life. Hand in hand with that, so keeping a change of clothes and toilet paper, and also water to hand or alcohol gels, things like that. Wearing comfortable clothes that are easy to pull on and off. Depending on if the diarrhea is a chronic diarrhea, a commode in your home might help, especially if you've got mobility problems, which would stop you getting to your bathroom quickly. And then kind of every day for all of us, sensible hygiene precautions. So we're even more attuned to this given what's happened in recent years. So always washing your hands with soap after going to the toilet, and using moisturizer after washing your hands are dry, just to make sure that you then don't end up with dry skin on your hands. So the kind of running theme throughout all of this has been talking to your healthcare team and making sure that you report any symptoms that you're worried about. There really is no need to feel embarrassed. I know it can be quite an embarrassing subject to bring up or topic to discuss, especially if you come to your hospital appointments with family members, but we're well used to having these conversations. As hopefully you can see tonight, I'm quite happy talking about bowel habits and things like this. And I can probably speak for most of my colleagues in healthcare that this is what we do on a daily basis. And hopefully I've managed to reassure you that we have a lot in our armory that may be able to help you. But it's about having those conversations and letting us know that this is what you've got going on, so we're then able to try and help. The reporting changes to your usual bowel habit, so lasting more than a few days. So again, knowing what's normal for you prior to you starting any treatment means that we can then have a conversation about knowing what's abnormal and then moving on to investigate and manage that. We're able to prescribe you treatment, as I've said, to relieve your symptoms, and hopefully I've shown you that there's a whole array of different stuff that we can give you to try and help. But it's important to talk to us first, especially before you may think of trying any over-the-counter remedies. People may not want to bother us and might want to try some self-help stuff first, but it's really, really important for all of the reasons that I've outlined that you do just give us a call first. So speak to your CNS, speak to any kind of 24-hour hotline that you may have just to get that advice before you decide to take anything over the counter. And then really important, if you find blood in your vomit or your poo, then it's important to seek medical advice immediately. So don't wait until the next day until your CNS may be back in. I know it's well publicised at the moment that accident and emergency isn't a great place to be, but it's the only place to be if you're finding that you've got blood in your vomit or your poo. It's really important that you go and get that addressed immediately. Thank you very much. I'm going to hand back to Monica, I think.
Great, thank you so much, Craig. Huge amount of information there, and I think it just illustrates how sort of common these problems can be, but also what help there is out there from your team, but also there's a lot of self-help techniques and just trying to prevent some of these things from happening as well. So we've come to our question and answer section of today's event. So thank you to all of you who submitted questions beforehand, and we've had some live ones as well. So we'll do our best to get through as many as possible in the time that we have. So just first question is actually related to AL amyloidosis. I've had a question from a few patients on this. They want to know if there are similar gastrointestinal symptoms with AL amyloidosis too.
Yep, so the short answer is yes, as many of the treatments that we give for AL amyloidosis are the same as what we would give for myeloma. So they come with all of the same potential side effects and complications. What I would say is that AL amyloid as a diagnosis can directly affect the gut itself and can cause symptoms prior to us starting any treatments. So symptoms like diarrhea, worrying, blood loss and weight loss due to malabsorption, and also difficulty swallowing. So the amyloid itself can cause some of these GI disturbances that we've discussed.
Great, thanks, Craig. So definitely the same message as getting in touch with your team, getting to find out what the cause is.
Yes.
You mentioned in your talk about probiotics. So we did have a question submitted before the session from Kirsten. Kirsten wanted to know: is it safe to take pre and probiotics?
Yeah, but this is a difficult one. So it's a contentious issue and has been for a long time, ever since I've worked in hematology. Are we safe to use pre and probiotics? Again, it sounded like a broken record. I'd seek advice from your treating team. But in general, we in Clatterbridge advise any patients on chemotherapy not to use pre and probiotics. And that's because these are live culture mediums. So the live bacteria that you're putting into a system that's already compromised because of chemotherapy. So it may actually have a counter effect to the benefit that you would get if you weren't on chemotherapy. I think there's probably more research to do in this area, as there's a limited evidence base. And I think that kind of one rule fits all of anybody on chemotherapy shouldn't take pre and probiotics is a little bit outdated. Given that a lot of the chemotherapies now, particularly in myeloma, don't suppress the immune system as much as traditionally was the case. So we're not seeing the neutrophils type of white blood cell. We don't find that most of the treatments with myeloma, we're not suppressing those neutrophils to a degree that would make us worried about things like pre and probiotics. Say for somebody who's going through a transplant for leukemia, where they're very neutropenic for a long period of time, somebody like that definitely shouldn't have pre and probiotics. But I think there's probably a role for them in certain situations. But seek advice from your healthcare team first. And just a note on this for, again, anybody who's interested, one of the treatments now that's coming to the fore for the particular type of infection that I mentioned, so Clostridium difficile, is to use stool cultures that have been prepared in a lab to try and redress the balance of the good and bad bacteria in people's guts. So I think done in a controlled way, yes, there probably is a place for pre and probiotics, but what that controlled way is, then I can't say for certain here, given that there is a limited evidence base.
Yeah.
Hopefully that's me not sitting on the fence too much.
No. Well, I think, more research required. Obviously, when there isn't the evidence, it's hard to say, isn't it? So
yes.
On the theme of infections, we had a question earlier from Karen. Karen said she ended up in hospital recently for a week with an infection in her gut. She asked what she can do to improve her stomach health in order to limit these types of infections. I think, you've covered some of this in the talk. Is there anything extra, to answer to that?
I think it's difficult to answer it specifically without knowing more detail about what the infection is or was and what the treating team thought the cause of that might have been. So it depends on what current treatment Karen may be taking and then what investigations she had into the cause of this. But in general, yeah, all of the things that I've mentioned in the talk as part of the self-help sections and seeking advice, maintaining dialogue with your treating team, I think are the top in maintaining your gut health.
Great, thanks, Greg. Something that a question that wasn't sort of covered in the talk is from Brenda. Brenda has been diagnosed with diverticulosis and wanted to know, is this something that might have come about because of myeloma? What is diverticulosis and what's the difference between that and diverticulitis? So lots of words.
Really good question. So I'll deal with what it is first. So diverticulosis describes the process that is going on in the gut. Diverticulitis is that then becoming infected and causing the symptoms. So diverticulosis is pockets within the intestine where food and things like that and stool can get stuck. And then diverticulitis is when that causes inflammation and causes your symptoms of stomach pains, diarrhea, things like that. Is that something that's likely come about because of the myeloma? Not directly, no. It's unlikely. It tends to be something that is caused by diet, so a low fiber diet in particular, then has the complication of diverticulosis. However, some medications, such as antibiotics that we may have had to use during the period that you may have been on treatment for your myeloma, if you picked up infections, chest infections, then antibiotics can exacerbate diverticulosis. There are other risk factors to developing diverticulosis, so advancing age, smoking, and obesity. So generally trying to lead a healthier lifestyle, which we all should be trying to do, and increasing the amount of fiber in your diet are other things that will help maintain your overall gut health and hopefully prevent you developing diverticulosis.
Great. Thanks for clarifying that, Craig. Just looking at one of the live questions that we had during the talk about getting a churning stomach after taking steroids with a carfilzomib infusion. I think this was this Paul? But he's fine until he goes to bed, then turns on his side. If I lie on my back, I'm fine. This happens for a couple of nights and I'm fine until the next week's treatment. So it seems to be tied to treatment. Any ideas on what I can take, not feeling sick? So it's this churning stomach after taking steroids and carfilzomib.
Yeah, again, I would seek advice specifically from the treating team. Depending on what they feel may be going on, yes, there are things that you may be able to take. So those drugs that are listed under the antispasmodic drugs can help with a churning or a gurgling stomach. So things like buscopan, bearing in mind that they also can come with side effects themselves. There are self-help things that if you think it's the steroids in particular, so trying to take your steroids as early as possible in the day, trying to take them with different things. So trying to take them with milk might help, making sure that you don't take them on an empty stomach. All things like that may be able to help the symptoms that you're getting.
Great, thanks for that. We've had a few sort of questions on a similar theme about sort of more longer term problems. So there's a question that came in earlier from Stephen. Stephen says, I'm in remission, but I have adverse effects on my gastro functions. Why is this? Any thoughts?
So without more specific information about what those adverse effects you're experiencing are in your other medical history, again, it's difficult for me to be specific about my answer. What I would say is even if you're in remission, there can be long-term effects from prior GI disturbance that you might have had whilst you were on treatment for your myeloma. So as I mentioned in the earlier slides, some of these GI disturbances can be chronic. So again, seek advice from your treating team just to see if they need to investigate the symptoms that you're getting further. And even in remission, again, going back to the long-term treatments so that we use for myeloma now. So you may be in remission, but you're on a long-term treatment such as lenalidomide. And if you're on lenalidomide long-term and you're getting GI disturbance, especially diarrhea, then we may need to do that specific CCAT scan just to check that it's not something to do with bile acid malabsorption. So yeah, definitely speak to your treating team and just see if there's anything they want to do further to investigate the symptoms that you're experiencing. Great.
I think we also had a question from John. I think this is perhaps similar, but since this stem cell transplant, the chemo has affected his ability to pass a normal stool. Unless he takes loperamide on a regular basis, he would have chronic diarrhea. And is that typical after a stem cell transplant to have this diarrhea?
Good question. So yes, GI disturbance is a very common side effect of stem cell transplant. So it can be long-term or chronic or acute, depending on the type of transplant. So obviously in myeloma, the most common type of transplant for those that are eligible is an autograft, having your own cells back. But there are still some people who may have had an allograft or somebody else's, a donor's stem cell transplant for their myeloma. And chronic GI disturbance is much more common in somebody who's had an allograft, as there's a particular complication known as graft versus host disease, which can affect the gut and can cause chronic diarrhea in particular. What I would say is chronic diarrhea in particular needs reporting to your treating team, again, as further investigation might be needed. And they may want to consider referral to a specialist, so somebody like a gastroenterologist who may be able to help you manage the symptoms depending on what they find or think the cause might be.
Great. I think we've got time just for one more question. This is a question from Simon about laxatives. So thinking more about constipation now. He asks, can some oral laxatives cause liver and kidney problems more than others?
So all medications, including laxatives, can cause liver and kidney problems. So this depends on how the body metabolizes them, so how the body processes the medications, and then also how they may be excreted. So some medications will be excreted through the kidney. So yes, laxatives are no different to any other drug. They can cause liver and kidney problems. Again, hard for me to be specific about certain types, but this is why it's important to speak to people first before you start on any medications, because they'll know what your normal kidney and liver function is. And if they're worried about potential adverse effects from certain medications, then they can put in safety netting so they can make sure that they're keeping a closer eye on your blood checks if that's something that they're worried about in your case. What I would say is laxatives, if you take them in large quantities, as I said in my talk, will then cause diarrhea, which in turn has the knock-on effect of causing the kidney problems because of dehydration and fluid loss.
Sure. Great, thanks, Craig. Really, really comprehensive answers to those questions, and thanks to everybody who put those questions in. I'm afraid that's all the time we've got for the questions today. I will give some details later if you've asked a question and not had it answered, how we can help you with that. But I'm just going to pass back over to Craig now, just to do a little roundup of some take-home messages about the talk.
Thanks, Monica. So yeah, I echo Monica and Myeloma UK in thanking you all for joining us again tonight. And what we've covered in this talk is what GI or gastrointestinal disturbances are, what can cause these in myeloma, and then how we can treat and manage such disturbances. And then just 3 take-home messages to leave you with. So GI disturbances are common for myeloma patients, but hopefully I've managed to reassure you that if we know about them, then these can be managed, usually in a way where we hope that it's not going to interrupt any treatment you may be on for the myeloma too much. The biggest take-home message, and this one should be in red or in lights, is that patients should report GI disturbances to your healthcare team. So there really is no need to feel embarrassed. We need to know about this, as there are things that we can do to help. And then sticking to a healthy diet with lots of fiber, taking regular gentle exercise. As I say, that may not be going for a run or walking around the block. It may just be getting up from the couch and walking to the kitchen, grabbing yourself a drink of water and sitting back down again. Just regular gentle exercise will help, and taking your supportive medications as prescribed by your doctor, but also reporting if you don't need any of those supportive medications, so you're not continuing with laxatives if you don't need them, or vice versa.
Great. Thank you so much, Craig, for going through all of that, and such helpful insights. Just like to mention some specific publications that you might find helpful for tonight's presentation. So we've got several treatment guides on our website, but one of the specific publications to mention is our Gastrointestinal Disturbances info sheet, which you can see a picture of on the screen. We also have the booklet, The Small Things That Make All the Difference. This is the booklet which you haven't already seen. It's the one that provides lots of quotes and hints and tips for myeloma patients, family members and carers. So that is a really nice, popular one. You can also order yourself a patient diary. This is where you can keep a record of your tests, record of appointments, treatments, and any of those side effects, these gastro side effects that we've been talking about. Give you a place to write that down and to also jot down questions for your team when you need to speak to them. We're very much here to support you, and we offer so many services where you can speak to somebody who understands. And I'm just going to go through some of these in a little bit more detail in a moment. So, we have our, first of all, we have our myeloma info line and Ask the Nurse email service. Our information specialists are available Monday to Friday, 9 till 5 p.m. And as well as the info packs and info sheets mentioned in the chat that Rebecca's been putting in the chat for you, we also have a range of publications you can download from the website and order in hard copy if you prefer. All of our previous digital Infoday sessions are up on our website and our YouTube channel, and you can watch them on demand. So do keep an eye out on our social media and website for announcements of new events. You also might have heard about our peer buddy service, which is relatively new. That provides a chance for patients and carers to tap into the knowledge and experience of other patients in a one-to-one setting and talk to somebody who understands, who's been through it. We also, in a similar vein, have a myeloma discussion forum. So that's a place where you can get involved in conversations with other people, ask questions, talk about, just share experiences about living with myeloma and those related conditions. And lastly, we have a range of support groups all over the UK where you can meet other patients, carers, and family members. And you can head over to our help and support section of the website where you can find all of the information that I've mentioned above, and the link is being posted in the chat. So we've just about at the end of our event today. So just really big thank you to Craig for speaking to us this evening. Really expert help. We have, I mentioned our clinical service excellence program earlier, and the Clatterbridge Hospital have been through that program. We know what fantastic care, and I think it's testament tonight with Craig's insight and helpful tips and reassurance, hopefully. So thank you, Craig, for taking the time to spend with us tonight. We're very grateful. Also, I'd very much like to thank all of you for joining us tonight. We hope you found it helpful and informative. As I said, I'm sorry if we didn't get to answer all of your questions. We have had a lot of questions in, a lot of interest in this webinar. Or listening might have prompted some new questions, so please do contact us and we'll help answer your questions. You can do this via the info line, which I mentioned, or our Ask the Nurse email service, and those contact details are on the screen now, but you can find them on our website. Thank you to all of our supporters. It means that Myeloma UK can provide free digital events like this one for patients and their families. So if you would like to support the work of Myeloma UK, please go along to visit www.myeloma.org.uk/donate. We're very grateful for any support. Thank you. And just to reiterate, you can rewatch this event on our Facebook page. So if you want to go back to it and look through it again or share it with others, please do so. It will be up on our website very soon as well. So finally, thank you again very much for joining us and contributing to this webinar. Hope you all enjoy the rest of your evening, and I wish you good night to everybody. Thank you. Bye-bye.